All right, well, welcome everyone. So here we're going to look at some of our secondary lymphoid structures, right? So in the previous part, we were talking a little bit about the primary structures, right? So where the cells, the lymphocytes are formed and where they mature. Now we'll look at some of these secondary structures where they go to become activated, right? And ultimately exert their effect, right? So here we're going to look at specific organs. We're going to look at two in particular in this part. We're going to look at lymph nodes and the spleen. And then we will continue talking about in a future part, looking at something called lymphoid nodules. Okay, lymphoid nodules. So first one here is the lymph node, right? So you've heard of lymph nodes. At least in passing. Lymph nodes are, when you go to your primary care provider and they feel in your neck, maybe they're feeling your glands, or feeling for enlarged lymph nodes, right? So these are kind of small, oval, encapsulated structures. Sometimes they almost look like little beans, right? If you ever identify them during dissection, right? They kind of look like little beans. You have these really all throughout the body, and they're kind of aggregated in certain areas, and their names are very descriptive to the region they're in, right? So cervical lymph nodes, axillary lymph nodes, superficial inguinal lymph nodes, you've got these in different areas, and these are receiving lymphatic fluid from some of those different vessels and trunks that we've talked about previously, right? And so, again, as fluid is coming into these, they can begin to filter the lymph, the lymphatic fluid, that is. You can also think about this, as we mentioned, in the context of a clinical setting where the lymph nodes are swollen, right? This swollen lymph nodes is lymphadenitis or lymphadenopathy. So think about why your lymph nodes are swelling, right? Why do they become increased in size? Why do they become larger during periods of infection, right? So take a second and think about why that is occurring, right? So the reason, the primary reason, is that during an infection, right, in which your lymph nodes are actively filtering, more lymph, and the cells in the lymph nodes are becoming activated, those cells are also proliferating and they're dividing, right? So as the T and B cells inside the lymph node begin to divide and proliferate, they increase in number, and as a result of increasing in number, they're going to increase the size of the lymph node, right? So we would see that as a swollen lymph node, right? So here's an image of a lymph node, right? So you can see kind of this small kidney bean shaped. You see several vessels bringing fluid into the lymph node, and then you see a single vessel taking blood out. So this is called your afferent vessel bringing it in, efferent taking it out. So the way you can remember this, A and afferent, think arrive, so the fluid is arriving at the lymph node, and then E and efferent, think exit, right? So the fluid is exiting, the lymph is exiting the lymph node, right? So notice also the number of these vessels, right? So you have more afferent vessels than you do efferent lymphatic vessels, right? So what this does is that it actually helps to slow down the the flow rate of lymph as it's leaving the lymph node, right? So you can imagine this, you've got all of these vessels coming into the lymph node, but you've only got a single one moving out, right? So the flow moving out is going to be much slower. The fluid's going to spend more time in the lymph node, and ideally, there's a greater exposure to the different immune system cells, right? So our lymphocytes that we have in the lymph node. And so if there's a pathogen, if there's bacteria, if there's foreign organisms in the lymphatic fluid, spending more time in the lymph node is going to allow those cells to recognize them, right? You've also got these structures called trabeculae. These are just these kind of connective tissue dividers that kind of separate the lymph node into these different compartments. And then you've got two regions called a cortex and a medulla, right? So the cortex of anything is always going to be the kind of outer, more superficial region. In this case, we have a region called the germinal center. And the germinal center is this inner region where you have proliferating cells. So these cells are beginning to divide, proliferate, and increase in number as they become activated. And you've also got these sinuses. And the sinuses are just openings where the lymphatic fluid can flow through as it's entering the lymph node, right? So again, in the cortex, these germinal centers, They're packed with B cells. Deeper in the cortex, you have T cells. And then when we get down to the medulla, you have both B and T cells, right? So in these medulla, these medullary cords, you contain both B cells and T cells, and you have more sinuses, right? So in this case, what are called medullary sinuses, right? Because they're in the medulla. So you can see this example over here. So you have your deeper medulla, right? The medulla of anything is going to be more deep. It's going to be more toward the core, right? So things like the adrenal medulla. There's a medulla of our kidney, right? And then likewise, you have a cortex of those organs as well, right? So here you can see your cortex, this outer region, and then you have these kind of circular, spherical clusters of cells called lymphoid nodules, right? And we'll talk about lymphoid nodules in a future video, right? So again, outer cortex, inner medulla. Here you see a medullary sinus, right? Again, where lymphatic fluid is flowing and encountering macrophages along the way, right? And those macrophages are phagocytic in nature, right? So they will cellularly eat and engulf any pathogens that may be circulating in those sinuses, right? So this is kind of showing, again, kind of a progression of the flow of lymph through our lymph nodes. So again, it's coming in through several different afferent lymphatic vessels. Remember, the afferent are the ones that are bringing it in. It passes through the sinuses, through the cortical sinus, through the medullary sinus. Macrophages, lymphocytes are becoming activated. They're proliferating, causes these enlarged nodes that we mentioned earlier, and then the lymph is going to exit via a single, usually one or two efferent vessels, right? And again, that's helping to slow the flow down because you have several afferent vessels, but only a single efferent vessel, right? So last thing here with lymph node before we move on to spleen is lymphoma, right? So you've probably heard of lymphoma. This is a cancer of lymphoid structures, right? Typically starting in the lymph nodes. So you may have enlarged non-tender lymph nodes, night sweats, fever, kind of non-specific symptoms, right? Kind of general, vague symptoms, maybe almost feel like you have the flu, something like that, right? But the key here is you have weight loss. It also is going to persist longer, right? So with lymphoma, there are a few different types. One called Hodgkin's lymphoma and one called non-Hodgkin's. For both of these, the 5-year survival rate is relatively high. So this is a statistic that is describing the number of individuals or the percentage of individuals who've been diagnosed with a particular cancer, how long or what percentage of them are still alive 5 years after that diagnosis, right? So for Hodgkin's, it's about 90%, and for non-Hodgkin's, it's somewhere around 70%, right? So these are you see these in different individuals right across the lifespan. Typically, Hodgkin affects younger people and then individuals over 60, and then non-Hodgkin's can affect usually kind of a wider range. So chemotherapy, radiation are typically treatments for these. There's also a cellular kind of distinction between the two. There's a cell called a Reed-Sternberg cell, and this is a characteristic cell type of Hodgkin's lymphoma, right? And it's essentially kind of this double cell that is fused. It kind of has these two large nuclei, and this is, again, it's just a characteristic of Hodgkin lymphoma, right? So secondary structure that we'll look at is the spleen, right? So our spleen is an extremely large lymphoid organ, as we'll see in just a second. This is in your left upper quadrant, right? So if you think of your anatomical terminology and the positioning of your organs that you've kind of talked about in more introductory anatomy and physiology discussions, your spleen's in your left upper quadrant. It has a hilum, just like there's a hilum of the lymph node. The hilum of anything is where things are entering and exiting, right? So it's usually kind of toward the middle of the structure, right? So in this case, you have splenic artery, you have splenic vein, and it's surrounded by a capsule, right? So if we look here, you can see the spleen, right? This kind of outer lateral convex edge, and then this more medial concave edge, right? Here's your stomach, here's your liver, gallbladder, there's your spleen, right? It's supplied by this large tortuous splenic artery, right? Remember, splenic artery is a branch of your celiac trunk, and your celiac trunk is a branch of your abdominal aorta. So there'd be a splenic artery. There's also a splenic vein as well that's ultimately going back to help form our hepatic portal vein, hepatic portal vein takes blood into the liver, so you can kind of see part of it here, and then the hepatic portal vein will ultimately branch into the hepatic veins, and then the hepatic veins will drain blood into the inferior vena cava, and then from the inferior vena cava back to the right atrium, right? So if we look at the spleen's histology, there's two different types of tissues. One is called white pulp, and one is called red pulp, right? And these are going to vary based on their appearance, so their color, but also the type of cell that you find there, right? So if we look here, you can see red pulp and white pulp. So red pulp is called red because it appears red because of the number of erythrocytes, right? So primarily red blood cells. You find here also some platelets and maybe some scattered white blood cells. White pulp, it's not white, so it's not called white pulp because it's white. It's called white pulp because it contains lots and lots of white blood cells, right? So that's where you get the name white. So really these large spherical clusters, you can kind of see one here, a large one here, another one right here. These are the white pulp, and these dark kind of blue, purple, black structures that you see here, those are the nuclei of our lymphocytes, right? And so that's what gives it this kind of dark color. But again, it's white blood cells, so you call it white pulp, right? So again, red pulp and white pulp. So the function of our spleen is essentially to filter the blood as it moves through, right? So our spleen and our kidney are kind of our two blood filtering organs. But it's also looking out for pathogens as well, right? Where the kidney is not necessarily doing so, right? You have these sinusoids. Remember, sinusoid is a type of capillary. There are macrophages lining the sinusoids in the red pulp, and those macrophages, as we've mentioned, are phagocytic in nature, right? So they'll engulf and eat any potential pathogens that enter, right? So this is kind of the flow of blood into and out of the spleen. So you have the splenic artery, which is a branch of the celiac trunk. Splenic artery goes into the central artery, or branches into the central artery, which is kind of in the core of this white pulp, so it'd be right here, kind of in the middle somewhere. Central artery into the sinusoids, which are those capillaries, and then into venules, splenic vein, through the liver, inferior vena cava, and then ultimately back to the right atrium, right? So you can have damage to the spleen, right? Some type of trauma, some type of penetrating wound, a gunshot wound, stab wound, something like that, automobile accident, right, things like that, that can cause damage to the spleen and potentially a ruptured spleen, right? So in this case, you'd have a procedure called a splenectomy, right? So you can see root word here is spleen, and then ectomy means to cut out or to remove, right, or to excise. So here you are removing your spleen, right? And so you can live without a spleen. However, it increases your risk for infections, right? Whenever you no longer have a spleen, you no longer have this kind of blood filtering organ, you increase your risk for infections, right? So an easy way to remember kind of where the spleen is and what you should do if you have a ruptured spleen is this kind of 911 analogy, right? Or this 911 mnemonic or way to think about it, right? So the 911, 911, 911, the spleen is in between ribs 9 and 11 on the left side, and so if you damage the spleen in between ribs 9 and 11, you should call 911, right? So that's the kind of way to remember not only the location but the potential for massive blood loss if you do damage the spleen, right? The spleen is sometimes called a blood reservoir. Lots of blood is stored in the spleen, so damage to it, ruptured spleen can result in significant blood loss, right? So we'll stop here, and then we'll pick up in the next slide talking about a few other secondary structures like tonsils and lymphoid nodules.